So before we get to our keynote, I want to again thank our team from SFBayCRN and Impact for the many, many hours putting together this meeting. And a special round of applause for Saji back there behind the... You want to stand up, Saji? Who made sure all the slides arrived and showed up on time. And everything else that you've done. Really couldn't do this without you, Saji. I also want to remind you to not just share your feedback on this one-page form, but also look at the back of your program. There's a QR code, and we very much hope that you'll take a moment to fill out those few questions as well. It'll help us plan for future meetings and know how you liked your experience today. We're hoping to share and incorporate all your feedback into our programs, and we thank you very much. Okay, so this is the presentation you've been waiting for. Dr. Peter Chin Hong is a professor of medicine and associate dean for UCSF's research campuses. He's been one of the leaders of institutional and community education around COVID-19 and MPOX. He has been part of numerous university initiatives, including outreach to the Asian American community, the Association of Black Cardiologists with their national webinars on the impact of COVID-19 on minority populations. He's helped create and disseminate a petition validating protest as a response to structural racism in COVID times. He's also advocated for the right to safe living conditions for those who are incarcerated or living in residential care facilities confronted with COVID. He's also a highly respected local and national commentator on the COVID-19 pandemic. I'm sure many of you have seen him on broadcasts or heard him on the radio or in UCSF town halls. And today, he's going to share his top 10 lessons learned from the COVID-19 response and a way forward for all communities. After his talk, depending on how you're all feeling, there may be a brief moment for a few questions, and then we hope you'll stay for a reception, a late reception afterwards that'll be in the hallway here. Thank you so much and welcome, Dr. Chin Hong. And you're going to have to hold the microphone because I don't know where the thing went.
Thanks so much, Michael. And thanks to everybody for staying on a Friday afternoon. Oh, great. No, I can hold it. I like to hold my microphone because I can rove around and can, get people to answer and talk and things like that. I really love the list that you all put together in small group, and it really resonates with a lot of the top 10 things that I was thinking about as I reflected on the last 3 years. But there are also some things that I think you came up with that I hadn't included yet. And, I think what it means is that, as we move along and we take stock of what happened in the last 3 years, that we will continue to refine these lists of what priorities are, and it becomes a living document. So thank you for all your work. When I reflected on giving this talk, I remembered back in the early months of 2020 and how, taking care of all these patients in the hospital, there was so much distance between us and the patients. And we were wearing all these masks, patients were alone, so the mental health that you brought up was so important. Patients were dying alone, they were on FaceTime, nobody could be in the rooms, and I think, what some of us started doing was just taking around pictures of ourselves to show patients what we looked like, because again, that human aspect was lost for so much of COVID, and I think that's really why mental health came up on so many of your topics. But, coming to the top 10 list, I like top 10 lists because they kind of make us consolidate things. I think one of my first lessons over the pandemic was health is political, and politics leads to health. And of course, this audience is no stranger to all of these topics, but I think much of the country didn't always know this. And I think part of the reason why we did so poorly, and I'll just show you some overall graphs, is that we didn't have health and politics necessarily intermingled, and they didn't inform each other, except in some areas like San Francisco and the Bay Area, and California, which we are so lucky to be in. So the mask became a symbol of not just taking of healthcare, but of political affiliation. I remember when early on, again in 2020, when everyone's wearing masks, going to get my a spare key, and the person making the key said, you know, what do you think about masks? You know, I think they're a bunch of rubbish, and I also like ivermectin. So I think it became a shorthand for knowing where people stood, which was really, really didn't make a lot of sense to us in healthcare, because again, we never really thought about masks as being political, but they came very political. And when you look at you know, where we were in terms of how we did compare to other developed countries, we ranked last. And you can see on the left here that you know, we certainly ranked overall last, in you know, worse than Belgium, Britain, France, Japan, Australia, etc. But when you look at the cumulative deaths during the Omicron wave, we also ranked last. In fact, the distance between us and the rest of the world was even greater, which really speaks to the fact that you can't really erase some of the foundational structures that were in place, even if you have a more forgiving political affiliation. And that theme comes up over and over again when you look at disparities that continue, even with a more responsive CDC and all of that. You really can't erase some of these structural barriers. And when you look at the deaths in the US linked to political affiliation, it's really striking, with the, you know, in the blue, had the lowest deaths per 100,000, and in the red, you had the highest deaths per 100,000. Of course, it's not adjusted necessarily, but it is really a stark reminder of how much political will really plays into health outcomes on a macro level. And when you look at California data, it's also very similar as well. So lesson 2 is we need to work fast, and that requires agility, strong communication, and alignment. And of course, we didn't work fast in COVID. And as you brought up in some of your groups, the delays in testing and this magical thinking cost lives. And, you know, in the beginning, we had to develop clinical criterion because we didn't have tests, and that was really dark age like medicine, where we had a PCR test available that the WHO had it already developed. The US said, we'll develop our own, and then there were delays, and the test didn't work, and that took a lot of time, and in the middle of that, lots of people died, lots of disease got transmitted, and we had a chance to redeem ourselves during MPOX, and again, there was a delay in rolling out a test that was already there nationally. Even, you know, we already had the PCR test, we already had stockpiles of medicines, tecovirimat, and we had a vaccine. So of course, this time really costs lives, even though I think most people thought at the end of the day, MPOX was successfully dealt with. It's only because MPOX really, the epicenters were in the 3 most liberal cities in the US, Los Angeles, San Francisco, and New York. So because of that alignment between politics and science, it really, even though there was a delay in many of these things, it really sort of was able to be more easily surmounted. And of course, there are biases as we unfolded the epidemic in terms of where testing was available in different communities. I think the third lesson that I learned over the last 3 years or so now is hate is a virus, and it reminded me a lot of HIV, and I think it reminded a lot of people of HIV. And when MPOX came, there was also a lot of hate. So every time there's anxiety in the population because people feel personally vulnerable, that leads to a lot of hate. And we saw it a lot in vulnerable populations and minority populations, and particularly amongst Asians. So when you look at the data from the Center for Study of Hate and Extremism, it showed an increase in 339% in anti-Asian hate crimes between 2020 and 2021, and there was already an increase between 2019 and 2020 of 124%. So it just kept on getting worse. New York, LA, San Francisco were most affected. But what was really interesting was despite this big delta in Asian American hate crimes, Black Americans remain most targeted in most cities in terms of the overall group most affected by hate crimes. And this is a quote from John Yang from the Asian Americans Advancing Justice. He said that especially during a time when groups are trying to divide and pit vulnerable communities against each other, we must remember that we are stronger together. And this is a picture from the Black and Yellow Asian Solidarity Rally. So I asked Betty Yu, who is in parts of this talk I'm going to weave together people I asked to give comments because it will be more interesting than me just sort of like blabbering on. And I think some of their comments and some of these reporters were really insightful because they were really looking from a community perspective. Suffice to say, these folks are really articulate in describing how they felt from a community perspective. And Betty Yu, who's a reporter for KCBS, talked about the fact that she was really, she herself was the recipient of a lot of hate online. And she talked about, really seeing the community generally stand up and fight and march, even though they weren't necessarily used to doing that in the Asian American community. So I think Betty herself responded to a lot of online hate, and that was really, really unfortunate. But people rallied around her, and I think in the Bay Area, again, we're lucky to see all of this happen so well. Now the advancing is, oh, here it is. So lesson number 4 I learned was that protest is a valid public health response, even in the middle of a pandemic. And I think that, what George Floyd showed us in 2020 was that, it was important for healthcare professionals to come in and really talk about, a public health threat, which is structural racism, that structural racism is a public health threat. And just like you deal with a public health threat of COVID by wearing a mask or by having social distance back in 2020, you dealt with a public health threat that is structural racism by making your voice heard. So as healthcare professionals, we weren't content to sit back and have people debate nationally about whether or not it was safe or hypocritical to go and gather in groups to protest because it was unsafe. So we, together with folks from CTSI and others in the university and in California, really banded together with the University of Washington and others, wrote this petition. It was signed by tons of people, got national attention. I was fortunate to be part of that. And what it did was it said that, yes, it was okay to protest. And not only was it okay, it was really imperative that people protest during George Floyd, in the aftermath of George Floyd. But here's how you can do it safely. And here's what law enforcement can do to make it safe as well. That is things like not having people in enclosed cars and questioning them, having masks and hand sanitizers available for people when they got, they were held for questioning. And I think that we then took this science-based view and said, okay, well, maybe since people are listening to the science, that we could use science and COVID as a way to really disentangle other things that were happening, like tear gas. So tear gas is banned internationally for warfare, but yet we were using it in the United States during George Floyd. So a few of us got together and said, hey, maybe if we used the connection between tear gas and COVID, law enforcement might think about it differently, or people were trying to disband these protests. So we talked about the fact that tear gas could increase people's ability to transmit COVID because it irritates the throat, and then people cough more, and there were more droplets. And it also increases the susceptibility of people getting COVID because it became more inflamed in terms of airways, and people were able to get it more. And I think that really had some traction in some communities. Like I know the mayor of Oakland got together to talk about that. In Portland, it was banned for a while. It was banned actually but then during the March of Mothers, it was banned locally, but then the feds came in and used tear gas again. So at least it brought up that conversation and gave a lot of attention. And what it taught me was that I think, in the health professions, we come from a position of strength, and people listen to us, and we can use science for good if used in the right way. And I think these examples really illustrated that for us. I think that lesson number 5 for me was engaging with the community, but not treating minority populations as a monolith. And we knew that in San Francisco, and again, it's preaching to the choir. But every group has its nuance. Every group needs something different. And if we could have listened to Christian Kaftan, he would have really spoken eloquently about the fact that in his experience, there was different things that different communities needed. And of course, we knew that really well in this audience, but not really well across the country. And I was fortunate to be part of that. For example, in the Asian American community, I think there was a lot of monolingual Cantonese-speaking population, so we really had to focus our efforts around language and access, particularly to older folks in materials. We tried to use science again to just blast the community with a lot of information about COVID, so that when people gave them sort of wrong information about COVID, they can respond sort of intelligently around it because they knew the facts. We also encouraged people to be upstanders. So I think that was the focus of the Asian Health Institute as one example of how different communities require different things over time. Oh, here it is. Oh, now we need the sound. I actually want to come back to Betty Yu if we can get the video for Betty Yu, because I think she was so powerful. Oh, I guess Betty Yu's video didn't come up, but let's see if Christian's come up. Can we try to get the sound from the AV?
Hi, my name is Christian Kaftan. I'm a television reporter for KTVU Channel 2 News in the San Francisco Bay Area. And certainly one of the interesting aspects of covering COVID-19 was seeing how it impacted various communities differently. Certainly for our Black communities, there seemed to be a general sense of mistrust of a lot of medical institutions and a lot of vaccine hesitancy, specifically in San Francisco. Again, some of that is understandable, certainly considering the complex history that African Americans have with medical institutions. One of the issues that was cited repeatedly, of course, were the Tuskegee experiments starting in the 1930s. For our Latino populations, we noticed that they had a very high rate of COVID-19 when compared to other ethnic groups in the Bay Area. And part of that is due to a whole host of socioeconomic reasons, including the fact that a lot of our Latino populations in the San Francisco Bay Area live in more highly dense neighborhoods. A lot of them were working in essential positions, so had to continue working through the pandemic. And some of them still relying on using public transportation to get to and from those jobs, and then possibly bringing COVID back to their families. So these were some of the issues that were facing our Latinx and Latino populations. And of course, San Francisco has a large Asian American population, specifically in San Francisco, a large monolingual Cantonese speaking community. Making sure that they were aware of COVID-19 wasn't the big issue. A lot of them seemed to be very aware that COVID-19 was an issue, but making sure that they were aware of the very latest medical advisories, medical orders, and quarantine orders, those types of issues, making sure that they were aware of a lot of that nuance was difficult because a lot of the information was given out in English and then had to be translated into Cantonese. So that was one of the difficulties there in learning how to do all of that. So some of the lessons that we learned in the media was that we have to treat each community somewhat differently and respect the differences of those communities, make sure that we can communicate with them in a way that they feel comfortable. We can't fall into the trap of treating any community as a monolith either. So just because it's an African American community or a Latino community or a Cantonese speaking community, we can't treat them as individuals. We have to treat them as individuals rather. We can't treat them as a monolith, and have to realize that we have to speak to each person individually and understand that they can take information as a whole. Now, of course, being in the media, I have a bias towards communication, but I was able to work closely with lots of medical professionals throughout the pandemic and making sure that we were able to try to get good quality information to various people and everybody really throughout the pandemic. And so that would enable them then to make the best decisions about what to do for themselves and for their families. And that was one of the critical elements, is trying to work on that relationship and make sure that that communication between the medical community and the various communities around the Bay Area was as clear as possible. I certainly hope that this information is helpful to you as you go on helping others. Thank you.
So that leads to the next lesson, which is that communication is key. And I think what we certainly learned during the pandemic is that you don't need to be an expert. You don't need to be the world's best expert in antibodies or T cells to really speak to the community. You really just need to be well informed and know what the limits of your knowledge are. And you don't need to stay in your lane. Each one of you is already an expert compared to the community. So don't be afraid of unleashing that. As I mentioned, aligning science and politics is really important in communication, and above all, using empathy. So I asked Raj Mathai from NBC to really, first Greg Liggins to speak about communication.
One thing I learned during the pandemic as it relates to minority communities is this prevalence of vaccine hesitancy. I saw this across age, gender, even to a certain degree, income lines. I think there are at least two reasons behind that. One would be the historical wrongs done to some minority communities. I'm referring, of course, to things like the Tuskegee experiment that people heard about and they just ran with that information. And then also the inconsistent and oftentimes contradictory messaging coming to us on both a national and local level. I'm not necessarily talking about the vaccine itself, but things like mask wearing, what you could and couldn't do indoors and outdoors. That messaging was just very inconsistent and really confused a lot of people.
And then Raj is going to speak about, again, putting yourself in someone's shoes. Initially, in my experience, people weren't always embracing all of these measures. But again, repeated conversations over time really help change people's minds. But that beginning conversation is really one where you use empathy.
Hey everyone, it's Raj over at NBC. First of all, thank you all for what you continue to do. I think there is some commonality here between how you're communicating with your patients and how I'm communicating with our viewers. These last 7 months have been hectic, right? So much noise, so much information, so much misinformation. I think the best approach that's working for me is just to take all of it, boil it down, and just with a lot of compassion and clarity, communicate with people. I think one thing, especially for doctors, you guys are so smart, but really just break it down in layman's terms, use some anecdotes. I think those are always helpful, and make it appear that that patient or that family member, you have all the time in the world for them. I think compassion goes a long way, and just kind of dialing things down a bit with your tone of voice, eye-to-eye contact, and using names as much as possible. Anyway, just a few tidbits from me. I'm sure you guys don't need much help, but again, thanks for what you're doing. And as we say in TV, we'll send it back to you.
Lesson number 7, disparities are amplified during a pandemic, and they still exist. And this is a really tough slide to see, but as this audience knows, and like I intimated in that first slide, we're still seeing a lot of disparities. So if the general population is in the gray bar, you can see that the Latinx population in the red is still above that gray bar. And when you look at American Indian and Alaska Natives in the yellow, it's even more dramatically high. So again, it really speaks to the fact that you can't really erase a lot of the structural inequities that we have in place, even if you have a more sympathetic administration. And it's something we need to continue to work on. I think one place where we're seeing a lot of that, of course, is in Paxlovid. So as people know, Paxlovid is a therapy used for early treatment of COVID to prevent hospitalizations and death. And if taken within 3 days of getting diagnosed, you can reduce your hospitalization risk by as much as 89, 90%, even if, particularly if you're not vaccinated. 3 pills twice a day for 5 days. In the beginning, when this was rolled out, you had to go on a website to figure out who had Paxlovid. And of course, that set up a lot of inequities. And I like this quote that spoke to that. The communities statistically most likely to need the services that are to be offered on the website are also the communities that are statistically most unlikely to be able to access it. In other words, this can actually increase inequity. This was said in early 2022, but as we went along in the Paxlovid rollout, the data suggested that there were indeed, and no surprise to most people, inequities in the neighborhoods that had access to it. In California and other places, this was the motivation for having pharmacists prescribe it directly without having a prescription, because the idea was that there were more pharmacists in more vulnerable communities, but the reality is that it probably didn't translate into a lot of people in vulnerable communities getting Paxlovid because there was still a lot of barriers. For example, pharmacists didn't always know what drug interactions patients had. They were afraid of some of those issues. So I think, and then people just not knowing about it. And also, you had to have a diagnosis to get access to Paxlovid to even know that you had COVID. And if you missed that window period, it wouldn't really be beneficial. So it really hinged on having diagnostics. And if free testing sites are being shut down and a test costs like $20 in Walgreens, even though you get $5 from the government, it's going to be a real issue. And when you think about a cost of a drug regimen for Paxlovid is about $500. So once it doesn't become a national public health emergency anymore, Paxlovid is going to go on the private sector market. So it means that people without insurance, again, would be saddled with something that they wouldn't be able to afford. So I think, we have to be aware of these barriers and new barriers as things are unfolded. A vaccine, Moderna released the price of a vaccine, and it's going to be between $110 and $130 for one shot. So again, these are all barriers to think about when this public health emergency gets disbanded on a national basis. Lesson number 8, pandemics are syndemics, which mean that if you have diabetes and you have COVID on top of that, you have an epidemic of diabetes and you have an epidemic/pandemic of COVID, the sum of the parts is worse than the individual epidemics themselves. And then, of course, money talks, like I was beginning to mention. The Biden administration asked for $10 billion to try to continue some of the services. But, of course, that was overruled by Congress, so not approved. So what it means is that efforts are really placed on Paxlovid right now, while it's still a public health emergency, and for vaccines, but not for a lot of other services. Again, once the public health emergency ends, it's estimated that there'll be about 18 million people who will lose some sort of coverage with Medicare, and about 4 million people who would lose insurance altogether. So I think these are all things that I'm sure you're aware of and that will be coming in the future. But at the end of the day, lesson 10 is the future is bright. All of you are in this room, and we need to continue to train our next generation. So one of the most fun things I did was really continue to talk about not just the science, but about communication. And this picture on the left was from fellows from the Association of Black Cardiologists that I did some media training with. And of course, on the right side are UCSF students who, from all 4 schools, who helped with doing mass drives when we didn't have a lot of masks early on in the pandemic, because a lot of Californians had masks kept away from the wildfires. So in the hospitals, we were lucky that the students were able to go out and do these mass drives early in the pandemic to make people feel more confident about all of this. And, based on all of your efforts and the sensitivity towards these disparities, at the end of the day, at least until the new booster, we were almost pretty much equivalent in many of the vulnerable populations in terms of vaccine coverage. That took a lot of work. And so I asked Cheryl Hurd to give a sort of summary comment about that.
Hi, I'm Cheryl Hurd with NBC Bay Area. It's been really tough covering this pandemic for the past 2 years. In the very beginning, people of color really apprehensive about getting the shot. Now, 2 years later, folks of color are getting it. Even my nieces and nephews, people I never thought would do it.
So where do we go from here? Well, I think that we'll continue to face threats at least every winter, maybe some spikes before winter. So this is not going to go away anytime soon. So all of your work will continue to count. I know you're going to work towards a brighter future in general, but all of these diseases, these infectious diseases are going to emerge at least every winter in various degrees with different things like RSV and influenza and so on. And that means, we need to continue to fight the good fight and make that effort. Where is COVID going to settle down? I think most people, we're still seeing about 500 deaths a day, even though mentally everyone's over COVID. That means that there are a lot of people who are still either not vaccinated. And what we're seeing in San Francisco is that people are vaccinated, but they didn't get the booster. And particularly for those over 65, that could really be the difference between life and death. And only about 40% of people over the age of 65 have gotten the booster. And in my own experience, those are the people who are doing poorly in the hospitals right now. We might have rushed out and gotten those vaccines to them in December of 2020, but it seems that everybody forgot about it for that particular population right now. So it's estimated that COVID will continue to kill about 100,000 people a year in the best case scenario. And again, that's a new threat. That's 100,000 more people than regular times that are going to continue to die every year. But we have the chance to change the ending of that story because many of these deaths, the vast majority are preventable either with vaccines, and even if you don't get vaccines, some of these early therapies. So I asked Michael Liu, who's the Dean of the Berkeley School of Public Health, to kind of give some summary statements of where we might go next.
COVID has shown us that we've got big problems to solve in public health. We still got much of the world's population, including 80% of the population in Africa, that still need to get vaccinated. We've got a broken public health system here in this country and in many parts of the world that needs to get fixed. We got a decimated public health workforce from decades of underinvestment in public health that needs to get revitalized. And we got an antiquated public health information system that needs to get modernized. We got deeply entrenched, institutionalized racism that underlies so much of health disparities in this country that needs to get dismantled. And we're fighting a losing battle against disinformation and misinformation that we need to get a lot smarter in fighting. And we really need to build a global early warning system for future pandemic before the next one strikes, which will require an unprecedented level of international cooperation at a time when the world is sinking into deeper and deeper nationalism and tribalism. So from a public health perspective, we got a lot of work to do. And if we don't figure out how to solve these big problems, any future COVID research would be like just putting a Band-Aid on a ruptured aortic aneurysm.
Thanks for your attention. I'll be happy to take any questions. I'm glad the videos worked at the end. I'm sorry I didn't put any memes on. I thought I was being, all evidence-based and stuff for town hall presentations, but at some point the organizer told me the only reason they put me on is because I was the only person to put memes on the talk. And people wanted to have those memes, so any cheap thrills will do, I suppose, to get your message across.
Thank you, Peter. That was great, and I loved the way that you embedded all of those clips from media people, which makes me feel like you know a lot of media people, and they've really relied on you as a trusted voice during the pandemic. So can you share with us a little bit about how you became that trusted source?
Yeah, that's a really great question. So nice to see you again. Yeah, so my relationship with media was really unexpected. I was kind of minding my own business, and in the beginning of the pandemic, the CDC was pretty silenced by the previous administration. They weren't giving us what we were used to getting. Like every time there's a flu outbreak in the past, we'd get these really detailed instructions from the CDC or Ebola. And then COVID came and there was silence, or like it was very, very general, or and it didn't really make sense to healthcare providers. So we started talking to ourselves and coming up with these pathways and distilling and trying to come up with guidance. And UCSF was very, very active in that. A lot of people at UCSF put their heads together and came up with very clear guidelines. We did it in maybe 11 different languages and did multiple versions. So what I did was I went to Twitter in those early days. I don't do too much Twitter these days, and we just shared it. And people all around the world looked at these things. Everyone was desperate because we didn't have enough tests. So we were using like, okay, if your white cells were low below this point, it predicts having COVID because people are using those things. We went on social media to tell people how to get access to remdesivir because not everybody had access and people were desperate because people were dying in the hospitals. We went to share when something new was coming on. So from that, I think first locally, like the Chronicle did a story on people going to Twitter to share information, and they actually did a photo shoot of me, which is where like they told me wear my scrubs and like walk and do all these random poses, and they put me on the paper. Again, it was nothing that was expected, and then suddenly, slowly, then local media started to talk to me, and eventually it was a place where I was using science in the beginning. But like Michael mentioned, I got myself into lots of other activities and projects as well, because I used my relationship with the media to influence or have them be sensitized to other social issues. Like we used the media a lot for San Quentin. When San Quentin was having an explosion of cases, we used it to tell the story that incarcerated people health wasn't just confined to the prisons, it was community health. And or I would just slip it in randomly if they wanted to talk about, I don't know, PCR tests or something. Then I'll say, well, San Quentin doesn't have a lot of PCR tests. And if it was a live talk back then, they couldn't really edit it out or anything. So I'll just say anything I wanted to at the end, respectfully. And so that was how the relationship started. It was a really fascinating relationship over the last 3 years. Eventually, it was talking to not international media, so like Korea and China and BBC, so all these things that I never expected to be on, but I was just like being myself or like showing them my COVID doll, and I guess it was really fun for me, but it was fun because I think we can, media really wants people to speak clearly and communicate effectively to the population. They're not, as long as you talk to them, and they're really, some people are more biased towards being sensational, but as long as you talk to them beforehand and tell them what your boundaries are, you can still communicate clearly, get your message across, and I think that's eventually what happened. So now I'm, talking about Justin Bieber getting sick, or I don't know, actors from Thor and celebrities getting disease is always a big reason from which you can rope the population into getting your message. And those are kinds of random lessons that I've learned. But it's been fun, and I think that UCSF was a great place to be for communication during COVID, because they really didn't put a lot of barriers. A lot of other institutions did and muzzled their healthcare professionals from speaking on media, but UCSF didn't. They said, go for it. And that's why I think for the pandemic, UCSF had a really big voice, in general, and I was just a piece of that. So thanks for the question.
Thanks. I think probably that's, I think, working? Hello? Yes. So I think that's a great place to end the meeting, is with the message of go for it. I think we should all go for it. Go for a healthier community. Go for collaboration, and go for good communication, and go for a nice reception next door. And I want to thank you all very much for coming and staying. And Dr. Chin Hong, thank you so much. It's a perfect way to end our day.
Yeah, thanks so much for all your attention.